Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare, and a commitment to quality is essential for every healthcare system. Join us each month as we discuss the latest advancement in quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. I am very pleased and honored to welcome to the podcast Dr. Don Berwick. He is the President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, IHI, which he co-founded in 1991 and led as its first CEO. He served as administrator of the Centers for Medicare and Medicaid Services, CMS, from 2010 to 2011, and has held faculty positions at both Harvard Medical School and the Harvard T.H. School of Public Health. A pediatrician by training, Dr. Berwick has dedicated his career to advancing high-quality, patient-centered care in the U.S. and around the world. Welcome, Dr. Berwick.
So pleased to be with you. Thank you so much.
Before we start, I want to thank you for serving as our keynote speaker at our 8th annual System Quality and Patient Safety Symposium in May. We were honored to have you and inspired by your message. Thank you.
It was a complete pleasure. I really enjoyed working with you and your many colleagues.
So tell us a little bit about yourself. How did you become the famous Dr. Don Berwick?
I'm a pediatrician by training and practiced for 20 years, always part-time because I also had an interest in healthcare leadership and management. I grew up in a really small town where my father was a GP, a general practitioner, and so he kind of got early on impressed with the medical sensibility. But practicing pediatrics in a very good medical center, I still saw things go wrong all the time. And I became curious about why that was and how come we weren't seeing the kind of continual improvement that actually has characterized so many other industries. We were sort of stuck at a level of performance that was good, but not the best we could. And that led me to a journey. I was sponsored to visit other industries. I came to know manufacturing companies, hotel chains, importantly, NASA. I spent time with NASA, and I started to see what it would be to manage quality itself, to actually focus on improving processes and services as a core strategy with a lot of science behind it. I discovered the sciences of improvement, and with several colleagues around the United States, started a nonprofit organization, the Institute for Healthcare Improvement, where I now am a senior fellow. And as you said, I was the founding CEO until I went into the Obama administration. I think I was A, bugged by what was wrong, and B, I saw the sciences that could help us do better if we would use them.
So you told a very powerful story of you taking care of a baby. You told it in the symposium. I'm wondering if you would mind sharing it with our listeners as well.
Yeah, it was one of the critical experiences for me. I was a young resident in pediatrics in the middle of the night doing an exchange transfusion on a little baby. Today, we don't do exchange transfusions in the United States. We don't need to because we can prevent the blood incompatibility that causes the need for transfusion. But in those days, it was common. So in the middle of the night, I went through the motions of starting to transfuse a baby, and it all went sour. The baby got very, very sick right in front of me, and I didn't know what was going on. My fellow came in and figured out the problem. The problem was that the blood bank in that hospital centrifuged blood when it got it from a donor and divided it into two packets, one of the clear liquid plasma and the other of packed red blood cells. And what you were supposed to do is when you received the blood from the blood bank, remix them. So you got whole blood, which was the right material to transfuse the baby with. I didn't see the plasma packet. It was dangling down out of sight. And that procedure to centrifuge the blood from the donor wasn't the procedure at the other hospital that I worked at, where I first was in pediatric intensive care. So I was caught. I mean, the baby got really sick. Thank goodness survived, but it was a near miss that scarred me. I felt at that time I blamed myself. I mean, it was, how could I be so stupid as not to see that other bag and not to know that procedure? Um, and I still feel terrible about it, of course, but through the years, I began to see the systems issues behind it. I was trained in a different system. This was the middle of the night. It was very dark in the NICU. I don't know why the nurse didn't remind me to mix the blood, but maybe there was a hierarchy issue that stood in the way, or maybe she didn't see the bag of blood. Now I could analyze that as a bad design, and that improvement would require redesign. And that's transition from uh, blaming myself to seeing the system as error prone. It was an important transition. Plenty of grist, plenty of episodes where things didn't go right. I think there and still now, we train ourselves to try so hard and to feel so responsible that we turn to heroism as the answer. Just try harder, and things will go well. But
So it dawns on me that the hero in healthcare has evolved right over the years, but still we have this image, at least as physicians, when we train and when we go out there, that we are the heroes. And what you have tried to do with IHI and all the national and international efforts is really to design systems to help us be successful. So no matter if you're new or you're more experienced, no matter if you are a resident in training or you have practiced for many years, no matter if you practice in this hospital or that hospital, this state or that state, there is a system that will help you be successful. So tell me more about those systems. Where did you get that idea? And then how is it implemented today in today's medicine?
the basic approaches to systems that you're talking about developed outside healthcare as organizations, especially high-risk organizations like aviation or nuclear power or aircraft carriers tried to be reliable. They rapidly learned they couldn't rely on individual heroism. People are trying as hard as they can already as they possibly could. Pilots don't want to crash, and people don't want things to go wrong. But problems have causes, and the sciences of improvement are trying to open our eyes to what those causes are so we could change the processes so they're less prone to the defects. That's the science. It has deep roots. Quality improvement in healthcare has deep roots in social sciences and statistics and engineering sciences and cognitive psychology. But combining those sciences and saying, like you said, how can we build a system that is much less error prone? Today, an airplane has failure rates in the range of 1 part per 10 million. 1 part per 10 million. In healthcare, we have evidence that most recent evidence, about 1 in every 4 patients in a hospital is actually harmed by the care because of uh,
So this statistics, what does it show us? That we haven't learned, that we haven't implemented the science of improvement?
not enough. We're making progress. In fact, at Houston Methodist, in my visit, I saw the progress. I saw the commitment to making things more reliable. But it's a culture change. We come out of a culture in which, it's supposed to be like the doctor's the captain of the ship, and you try hard things will be okay. And if something goes wrong, you didn't pay enough attention. We blame people. We put incident reports in nurses' charts. We criticize people, and we make heroes of some. That's not a good plan. Healthcare is learning. There are many cases now over the past 3 decades or so where healthcare has made substantial progress. Hospital infection rates now are lower than they've ever been. Surgical mishaps are less common. Patients are much less likely to get pressure sores from lying in their bed. All of these because we've changed the processes to improve, but creating an overall culture of improvement where everybody, number one, has the skills, knows how to look at a process, which is team-based because we're smarter together than we are separately, and where there's complete transparency. When something goes wrong, we say it, we know it, we notice it. You can't fix what you don't see. And these properties, a non-judgmental, optimistic, trusting culture, a just culture, is a much better one for making care what it needs to be. More recently, there have been other changes that I think are really important, which is to give patients and families much more voice, much more power. I'd say the more control patients have, the more voice they have, the better the outcomes are going to be.
So just to go back to IHI, when you started IHI in 1991, it was just on the heels of the publication to Air is Human, right? It was just published then.
It was actually 10 years before To Err Is Human.
Oh, 10 years
Yeah.
before?
Yeah.
Okay, I
To
thought.
Err Is Human came out in 1999,
Okay.
and it's in the quality chasm, these two really benchmark
Oh, I
National
thought
Academy.
it's 1990. So 1999 to Where is Human? Okay, that's fantastic. So you were before your time. So tell me how it was back then and what was the goal and how it evolved to today.
It was really amazing. IHI began with a grant from the John A. Hartford Foundation as a kind of little trial. If we took these lessons learned from other industries and tried to bring them into the hands of hospitals and clinicians, what would happen? What happened was enormous excitement. The people that signed up to join our courses, our teaching opportunities, our improvement projects, they were like, I don't know, they were mavericks. They didn't represent the mainstream of healthcare. Mainstream of healthcare was still waiting and watching, but they were. I can't tell you how exciting it was, and I have many friends from those years who we still enjoy our company, and they still are at it. We're still trying to make things better. So there were these pioneers around the United States and more worldwide. In many countries around the world, they kind of caught fire, and IHI became a kind of international partner in trying to bring scientific improvement into healthcare. When those National Academy of Medicine reports came out, To Err Is Human in 1999, 2000, and then Crossing the Quality Chasm, which was a much more comprehensive report, not just on patient safety, but on all the dimensions of quality, then things really took off. That was a very trusted organization coming forward with very dramatic findings about how much improvement we need.
So what IHI is doing for our listeners who might be in different stages in their career, what is IHI? How can you reach out to IHI? How can you learn from IHI?
A lot. It's I'm now a senior fellow there. I guess almost 40 years old. Um, it has a number of activities for the general audience, people that really want to get involved. You can just go to ihi.org and you'll see on the web all sorts of opportunities. The one that's my favorite in a way is the IHI Open School. What we did was we realized we just couldn't keep offering courses at a fast enough rate to teach the sciences of improvement. And so we began a web-based educational system, a school, the Open School. Originally, it was for students in medicine, nursing, health administration, pharmacy, any discipline. Students could take it, but more and more others are signing up, or their organizations are getting licensing, getting a license to use it. But that's a really easy way, and I think there's over 30 courses you can take now on IHI.org in the Open School. We have large meetings. I just came back from Utrecht in the Netherlands, where with the British Medical Journal, we had our annual international forum on quality in healthcare. There were, I think, over 2,500 people there from 60 countries. And it was, 4 days of just courses and workshops and celebrations as, we say all teach, all learn. So everybody's sharing what they're doing. There actually are, I think, 5 or 6 forums now. The biggest one is in the United States. This year it'll be in Anaheim, California in December. And on iChat.org, you can find it. And that'll be many thousands of people together learning and celebrating and working together. Most importantly, I think, in ways leaders, executives, leading physicians and nurses, so that they're learning how to lead improvement. We now have meetings. There'll be one in Singapore in August. There'll be one in Australia coming up. They'll have one in Latin America and in the Middle East. So practically every continent's covered by these we call them forums. And then there are more intensive opportunities. IHI can train you to be a very high level technical expert in improvement in flagship courses called the IA Improvement Advisor, and it's an immersion course. It's 4 weeks of very intense training on how to master the skills of improvement.
So you have open school courses, you have large forums, and then you have really immersion courses for people who want to become specialized.
We also have networks. That's really important. A big part of my work is with the Leadership Alliance, which is a network in the United States of 60 organizations that stay together. They meet together both in person and virtually. And it's like this very active and buoyant club, in a way, of organizations that really want to work. And the organizations are variable. They include hospitals, group practices, some dental practices, even some insurers are members of the Leadership Alliance. And we have its cousin in Europe, the Health Improvement Alliance Europe, which is another 50 or 60 organizations from a number of European countries that come together.
So I see that this is really an effort that is encompassing the entire world. Do we know what's the safest country, to get care? Are we measuring something like that?
We don't have, the World Health Organization publishes its own opinions of performance. I think France is currently rated as the highest performing health system, not just with respect to safety. This has to do with access and equity and quality overall. Are you following the science? Outcomes? Do patients actually do better? So there are higher rated systems than ours by far.
Really?
We're somewhere in the 20s or something in among nations in ranking of our health system performance. I have my own favorites. One is Sweden, which is doing a terrific job. And Sweden organizes its healthcare by regions or counties. And one partner county that we have is called Jönköping County, just west of Stockholm. And oh man, they're amazing. The whole region is organized around improving healthcare continually and redesigning. It's quite stunning. There are terrific examples of systems within the Netherlands. There's a great system run by nurses that involves outreach into homes to help people stay healthy and well, and help people with chronic illness do well.
So does
you can
it have to do with how the healthcare systems and specifically payers are designed in that country? Does it, as quality actually stems from the infrastructure of this entire country, of how healthcare is tackled?
Yes, it has to do with a sense of responsibility. Let's say that waiting times are too long. Is there someone in the country or region that can say waiting times are too long and we're going to work on it and here's the plan? So there's a sort of leadership backbone that can focus on what needs to be done and assure that resources are getting to the people the clinicians and others who actually can make the changes. So I think that it's a leadership issue. And in the United States, we don't have that. There's no real minister of health, or, if, for example, look at our terrible substance abuse problem in this country, taking, tens of thousands of lives. who's in charge? Who's responsible for saying, okay, we're going to get organized now, everyone, please help. Here's some resources and approaches that we're going to use and keep at it. That's rare in the US, unfortunately, because we're so fragmented. Other countries where, yes, if there's a national level payment system like in the UK, in Scotland and England and Wales and Northern Ireland, they can get organized. Right now they're having big troubles. All countries are, but in the UK, there's a long history of a decision to focus on whatever the issue that is on their minds right now: waiting times, or worker morale, or cardiac care outcomes. To leadership, payment systems can be variable. We have the highest rated system, France, is it's a mixed payment system. Um, but profiteering and profit driven payment are much less present in those countries. In the United States, the dollar has kind of taken over, and profit seeking, I think, has reduced the amount of investment going into quality of care. No country has it perfect, but we sure can learn from others. I learn every time I travel. I learn.
So, you encourage us to go to these forums and learn from other people from other countries, listen to what they're doing, and maybe try to adopt some of them. I'm curious to hear if we are actually teaching this in medical schools today or in residency programs today.
Not much, but some. And I think that patient safety and methods of improvement are more and more making their way into the curriculum. We've got a ways to go, but there are schools that are in the lead. And I really believe that students will eventually demand it. When we started the IHI Open School, it was in response to student demand. We polled 1,700 students in all health professions, and we said, do you want to learn about improvement? And the answer was overwhelmingly yes. And are you learning it on your campus? And the answer was overwhelmingly no. So there's a great need out there. Some schools are using the IHI Open School. They're actually taking those online courses and mapping them into their curriculum. That's not uncommon now.
Yeah, here at Houston Methodist, we are envisioning a Quality and Patient Safety Institute for that same reason, because we feel that the people we hire and put into, clinician roles, they were not trained enough in quality and patient safety. And because we lead with quality, our kind of motto is safety, quality, service, and innovation. Safety and quality are first. We found out that we need to invest, and we want to start that institute here so everybody can actually will be required to take some courses to enhance their basic knowledge. But what we find when we go to donors, it's always something that needs to be supported by philanthropy, is that donors don't really see, what is it? Why is it important? It's not exciting when we say the science of improvement. It's not that inspiring. So how might we learn from Dr. Don Berwick and inspire our donors to give to that cause?
Well, Dr. Schaal, first, I'm really excited about what Houston Methodist is going to do. Remember, with 9 hospitals, you already have a learning system possible among all of them. But I think you could be real leaders, and I'm so excited about your launching this institute. I think the energy lies in the stories. It's in the faces and voices of people, patients who have hopes and dreams that we need to step up to, people who have been injured. Finding patients in your wonderful system who still suffered from problems in errors in their care or safety issues, and having them speak. The voices of the communities we serve and the patients are the most powerful windows we have on what really needs to happen. And you're right, the wonky, quality science or process thinking or statistics, they're really crucial, but that's not where the heart is. The heart's in the faces and the voices. So I'd encourage you to more and more tell the story through the experience of patients. And I think patients can give energy to this by themselves joining in the effort. The Institute should be one in which patients, families, communities actually have not just voice, but power, in governance. And they're the ones, when they go out and tell their stories to potential donors, I think those donors will say, now I get it. The other thing is the problems in quality in healthcare, despite the excellence we have in many ways, the problems in quality are pervasive, which means almost everybody's experienced them. And in the donor community, if you can connect to those experiences, do you remember your friend who got an infection that they didn't have to get? Do you remember that kid who had surgery and suddenly a serious complication of surgery? Do you remember that member of your family who got diagnosed too late and died because from a preventable disease? Connect to the experience of people, and I think they're going to step up and help.
So one of my team member, Pavitra Bora, was actually sitting here right next to me and listening. She shared a wonderful quote from you saying that the work that we are doing is actually it's not seen, but it's seen in people that attend graduation, that attend weddings, that grandma that can see her children, things like that. So that was very inspiring to me. If we don't do our job correctly and there are errors, it really destroys lives.
It does. And the problem here is it is with all prevention. This is a form of prevention. As that quote said, the names of the people helped are not known. They're people to whom the problem did not happen.
Right.
The complication did not happen. So we can't count them the same way, but they still have faces. There's still names out there. And I think it has to begin with looking at what goes wrong with courage and transparency, and not blame, but honesty.
So we always track and report to the board serious safety events that happen in our system, and we grade them. And, when I started in my role, I said, we need to hear more of those, not less. We need to hear more reports of things that actually went wrong in different levels. We don't hear enough. And so one of our board members, a very respectable judge, said, well, if we hear more and we report more, how do we know that we're actually getting better? What would be your response to that?
It's a great question, but you're absolutely right. If a hospital tells me they look for serious safety events and don't find any, that's a hospital that's not doing it right, because it's everywhere. It's everywhere. So the first thing is to realize that. As for your board members' question, there are two answers. One is for specific targets. For example, now we know how to prevent central venous line bacteremia infections. It can be zero. You can count those. And so there are certain indicator conditions which we ought to be working on, certain kinds of surgical complications. And there's no one has yet come up with an overall safety metric. That would be hard to do and probably inaccurate, because there's no particular way to do it, but you can identify certain kinds of harm and certain kinds of defects in care and count those. That's one. The second is the culture, and that's crucial. In a safety culture, a just culture, a culture of quality, the staff know it. They will say, if you ask a staff person, if something goes wrong, can you report it and expect to be noticed and not blamed? Are you allowed to contribute to the design and redesign of the work you do? Does the system demand of you work that you know is waste, but you have to waste your time on it? And there are now very good culture surveys, but if I had to pick one answer to the judge's question, it would be, here's how we know. Every month, we go out there and we talk to our wonderful doctors and nurses, and we ask them about the water they're swimming in. And are we, the board and the executives, creating a culture which supports honesty, safe reporting, participative teamwork on improving processes, learning about how to improve, and that cultural index would be a really important answer.
So, one of the things that we are doing here at Houston Methodist is the Joy in Medicine initiative, which we fondly call Jimmy, Joy in Medicine Initiative. And we have a Jimmy tour. We are just going to conclude this year's tour a week from now. And in those tours, we go and ask our physicians, what brings you joy? In 100% of the rooms that I was in, and these are dozens of rooms across the system where many dozens of physicians come in and talk about what brings them joy and what hinders joy. 100% of those rooms, people stood up and said, what brings me joy is the ability to provide high quality of care to my patients. And I think we hear it not only from physicians, but from nurses and anybody that works in the healthcare system. If you feel that you can provide high quality of care, it brings you joy. Can you talk a little bit about that? Because I heard you mention the word joy, and I was overjoyed to hear you mention the word joy.
I'm so happy to hear about your work on this. Everybody, not just doctors and nurses, everybody, the person on the street repairing the street wants to have pride and joy in their work. People feel better in their lives when they're connected to the meaning and mission of their work and are allowed to celebrate it together. For us privileged to be in healthcare, it's even better. I mean, it's such a noble undertaking we're engaged in, and the public that we help is so grateful for what we do. So we start off with a full deck of cards to try to have joy in our work. Unfortunately, sometimes the managerial and executive climate, the environment of payment and surveillance, the belief systems take it away. They suppress the joy. They tell people, just do your job, or if something goes wrong, they blame the person instead of saying, well, how could we understand this better? They don't invest in the growth and development of staff. It's just get to work and do your job. And sooner or later, the staff lose their sense of meaning and purpose in the work, and they lose their joy. That is squandering. It's just squandering, because the amount of that resource, as I'm sure you're discovering in your tours, in your Jimmy project, that amount of energy is phenomenal. You couldn't pay for it. You couldn't possibly buy it, but it's
I
there.
always say it's priceless. It's
It's
priceless.
it is priceless. And leaders smart enough to call on it and to say, I know you're committed to helping people. Thank you. What are we doing to get in your way? What are the pebbles in your shoes that we're putting there and making it harder for you to do your work? What are the ideas you have about how to make your work even better? Where are we, this board, the managers, preventing you from feeling that joy, and then get to work on it? That kind of teamwork and respect between the management and governance structures and the workforce, that can open up this tremendous resource.
Yeah,
I get sad when I find organizations that aren't doing that, that are blaming workers or fretting, putting up barriers to communication or to understanding. That's sad.
yeah. So I think the premise there is that if you have an engaged, happy worker, clinician, then it will translate to higher quality of care to our patients. And so that's the why, to invest in the joy of the people who work for our healthcare systems.
And then they'll be the first people to step up to help make things even better if you have the mechanisms of improvement at work where they can all participate and help.
So you've been a pioneer, and you actually were before even the science of quality took the mainstream in healthcare. And you've seen a lot of changes over the years. And now we are in a phase which is very exciting and very frightening at the same time, where we have artificial intelligence and all these smart platforms, ChatGPT, bots that can talk to human beings. What do you see as a potential for really improving in this 1-to-4 ratio that you mentioned? Can we get better with the help of technology?
No question, yes. I think that first, as I said in my keynote speech last week, a lot is changing that we need to keep up with. It. The whole idea of quality has changed. So where before, in the early days, it was a technical question: did we prevent the infection? Did we get the surgery right? Did we get the medications right? That's all still important. But now I think that now we're realizing there's a bigger thing here, which is, are we a healing place? Are we a kind place? Are we a place where every human being is valued, where what matters to the patient is what we do? That's more expansive. And I think we can make progress there. Can AI and the new world help? Absolutely, yes. I don't think we've yet discovered how big that opportunity is or discovered all the risks. But early on, we already know, and I believe this is true at your organization, that ambient listening systems where the AI can produce the note that the doctor would otherwise be spending pajama time on that night trying to write. And those notes are just as good and even better than the ones the doctor would produce. We have AI assistants in diagnostics now, in radiology, soon in other domains where I, as a doctor, can have this uh, AI assistant sitting on my shoulder, helping me, giving me advice that I can take or leave. But that's really great. I think our diagnostic accuracy should improve with AI.
Yeah, so
And I think,
last year we did our Jimmy tour in primary care, and because we heard about the burden of pajama time, documenting after hours, and actually we could see it. We can log into Epic. There is a module there called Signal that you can see actually how many hours our physicians are working at night just to complete the work of that same day. And so we as leadership, we committed, and now today I can tell you 100% of our primary care docs have ambient listening, and the response is just amazing. I mean, people are crying
yeah,
tears of joy because they don't have to spend all this time documenting. The note is actually within 30 seconds, it's ready for their reviews.
I've heard that and seen that in enough places that I'm now confident in it. That's producing joy in work when you take away wasted time and allow people to get back to the patient, which is what they really want to do. So unfortunately, it's pretty expensive right now, but I hope the technologies will become much, much less
Yeah,
expensive.
so my line was, it's priceless. If we invest in the joy of physicians, it's priceless, but it's still too expensive. So if anybody, out of these companies listening to us now, lower your prices so everybody can have it, every physician everywhere. And also
I think
nurses,
that'll happen.
this is coming
Oh,
to nursing as well. The documentation burden of the nurses is also huge. We are committed to providing the best care once you're already sick. We're going to give you the
yeah.
drug when you're sick, but how about we even prevent you getting the disease in the first place? So I don't know if healthcare system, and quite frankly, I do not know if we ourselves are doing a good job in trying to prevent disease.
This is an unsolved issue. First of all, we do know a lot about prevention. I gave your colleagues a reading assignment. I'll do it to the listeners also. It's a book called The Health Gap. The Health Gap. It was written in 2015 by Sir Michael Marmot, who's a revered epidemiologist. And what Michael did was analyze really the world's literature on health and why, say, countries that have equal wealth can differ by 5 or 6 or 8 years in lifespan. Why do we have gaps? Why across cities? I don't know the numbers in Houston, but I know in Boston, between wealthy and poor areas in Boston, the life expectancy varies by 20 years.
Yeah.
So Marmot is saying, what does this? And he came up with 5 factors. There: early childhood experiences, the quality of the education system for kids, especially girls, the properties of the workplace, the health of the workplace, the ways in which a society deals with elders in terms of preventing loneliness and providing social support, and then community resilience issues like housing security and food security and criminal justice reform and environmental security and recreational opportunities. So those 5 pots, we know, and he shows in that book just how powerful these are in determining health. Health care doesn't appear in that list. Health care isn't actually a very powerful determinant of health.
Wow.
We're a repair shop. Hopefully, we keep people going and we do prevent some things, but it's the world we live in now. The hard question: healthcare is taking 20% of the GDP now in this country. So when you say let's have more public housing or more supported housing, more food security, or more recreational opportunities, where's the money going to come from? And right now, healthcare is pretty well confiscating a lot of those opportunities. So for a hospital system, say Methodist, it's a governance question. What's your job? What are you going to do? And I think there could be an argument made, it's not our swim lane, But if healthcare takes a pass on these determinants of health, the resources are just not going to be there to work on them. So I think we need a new strategic plan, really, a new sense at the governance table about what it is we're here to do. And hospitals, I'm not sure they need to lead all of this, but they sure need to be players.
What struck me when you mentioned that in the symposium is that how important our children are, and also how important our elderly community is. Let me ask you a question that I ask all our guests, and this is the last question for this podcast, which is, what does quality mean to you?
Well, in the healthcare context, quality means care and attention in exactly the form that I would want my children to have. It's a very personal idea. It's focused entirely on what matters to the person across all dimensions, not just technical care. It's not just a professional deed. It has to do with the whole sense of the attitudes we're with. I told a difficult story in my speech about my best friend who died a couple of weeks ago, pancreatic cancer. He had a biopsy done to determine basically his treatment and his diagnosis, a very consequential test. And it went well, technically. He didn't have a complication, didn't have a lot of pain. But when I spoke to him afterwards, his question to me was, I don't understand. When I asked them when the test would be ready, they answered 5 business days. He said, isn't there something wrong with that answer? You bet there's something wrong with that answer. That is not tuned in to his state, to his needs, to his who he was and where he was. And quality is the opposite of that. It's absolutely doing that transaction the way I'd want it for my kid.
So that story really hit a nerve, and many people came to me after your talk and say, Dr. Schaal, we never answer like that in Houston Methodist. We will never say 5 business days. And also, if somebody has cancer and we know that this is really, they're waiting, they cannot sleep until they get the response of the biopsy, we are doing it as fast as possible. And we know it's important. Another thing that I, kind of appreciate from this answer is that you said it's personal, and we tend, at least at the management level, to measure, things that are numbers. And it makes sense. However, we have to remember that quality is personal. So thank you so much, Dr. Berwick, for your really wise, inspiring words. I so much appreciate the time with you.
Thanks, Dr. Schaal. It's a pleasure to spend time with you.
And thank you for listening. Quality Time is part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you, and until next time, I am always listening.